Thank you, madam. And at the outset, I would like to thank Swapna madam for having included me in her IC. Today, I'm going to talk to you all about Femtorhexis. There are certain advantages and there are some limitations as well, and I'll try to present as unbiased a view as possible. Rhexis, as you all know, is a critical step in ensuring we have a good refractive outcome, especially when it comes to a premium IOL. A toric IOL having a well-centered Rhexis is important, as well as ensuring appropriate centration, avoiding tilt, avoiding capture of the optic through the larger Rhexis are all things which can be avoided when we have an ideal capsular exercise. Not to say that this cannot be done with a 26 gauge needle or a Rhexis forceps, which is what we all do predominantly. Even flax users, that's what we do predominantly. But still, there are certain obvious advantages. So before we go into some videos, a little bit of literature where definitely better circularity and uniformity has been shown both in vitro as well as in vivo in terms of femtosecond versus a manual CCC, and definitely the extent of repeatability and precision is certainly higher. The attempted versus achieved capsulotomy size is also extremely close with that of the femtosecond laser, as you would imagine, whereas we can't get that same level of precision with a regular manual CCC. Also, does this have an impact overall? I mean, in terms of the being in statistically significant data, if you would call it that, the size and circularity as well as overlap in various comparative studies have shown that it is better with the femtosecond platform, both in vitro as well as in vivo. Now, the question comes, what is the effect on decentration? So does it really matter, the uniformity, overlap and other things, or is the lens just going to center within the bag, irrespective of how your Rhexis is? It has been found that the horizontal decentration, to a lesser extent vertical, but more importantly the horizontal decentration is definitely lesser, definitely lesser with the femtosecond platform than the regular manual CCC. However, the circularity and centration may not have a direct correlation with the predicted postoperative refraction. As you can see, the dots are all over the place, both above and below, as well as the amount of decentration and predicted refraction as well. So, to a large extent, I mean, we can conclude that in monofocal lenses, it makes less of a difference. But definitely when it comes to a multifocal or toric, these decentrations and tilts will become more important. The earlier femtosecond laser was supposed to have these very jagged edges or posted stamp perforations where they believed there was a risk for extension of the Rhexis when we are doing an exuberant hydro. But that has really come with better with the optimization of the laser energy parameters. We definitely have much smoother cuts now, which are as strong as a manual CCC. And you can do a very safe hydro in these patients without any concern at all. So even these tags, postage stamp perforations have all been refined with better energy parameters. So just a couple of videos on the lens X. I'll show some on the catalyst as well. Video is not running. Yeah. So now it's running. So the advantage is you can really determine the size, the position, and achieve 100% of accuracy as far as the Rhexis is concerned. The time taken for the Rhexis is slightly longer with the LensX platform than it is with the Catalyst platform. But in both platforms, as you can see on the left as well as the right, in the left it's a nice free-floating one in the LensX platform, and in case if it is not free-floating and you've also done the segmentation and softening, you lose the red glow. So just to ensure that you are not missing out on any of this, you have to do a dimple down technique. That is, just press down and you will see the slight separation of the Rhexis from the periphery in all sides before you pull it out. So just a dimple down, press down, a nudging in one direction will show you that the Rhexis is free from all directions. In case if it is not free, then you can go ahead and complete it like a curvilinear Rhexis like you would do. So this is very commonly the kind of outcomes that you would get, a well-centered capsular axis and a well-centered IOL as well. In challenging situations also, you can have eyes where there is a lot of anterior capsular fibrosis, subcapsular fibrosis. Even there, the femtosecond laser is able to give you a very nice mark. You know exactly along the path where the femtosecond laser has made the cut, and all you have to do is just be a little more careful with either your forceps or your cystitome. You just have to go ahead to the areas of maximum capsular fibrosis and ensure it is well separated instead of directly going with your dimple down technique and removing it. And more often than not, they have absolutely fine. So as you can see here, that's the zone of maximum fibrosis where some amount of separation is required. But because the femtosecond has already created that channel, they don't extend, the axis doesn't extend, and as long as you just do the regular centripetal movement, you do very well. Why intermittent cataracts is an area where it really helps. I mean, you can have a nice, large-sized, sufficiently sized axis without any difficulty whatsoever. You can see these fluid clefts which are there on the OCT itself, and you can also alter the amount of time taken. In LensX, it takes a little longer, so there were occasional cases where you could have a small tag or an area where it is not yet fully cut. But however, in this case, as you would see here, it is actually a nice free-floating rexis and it's already along one side. In the catalyst, you can even reduce the amount of time that is required to about 0.7 seconds. So even before there is an egress of any fluid, the capsular axis has been completed. This is again a patient with a dense anterior subcapsular fibrosis, and this is another area where it helps again because the rexis goes around the area of capsular fibrosis and it can be separated very, very easily. So that's just the video where it is extremely easy to, just as you hydrate, already the rexis is completely separated and the capsular fibrosis also comes off along with it. These are again challenging situations where it really, really helps, where essentially the most difficult thing in a subluxated cataract is the rexis itself. So once the rexis is made, life becomes a lot easier. You can go ahead and remove the rexis, put in your capsular hooks and CTR, and then go ahead with the rest of the surgery very, very easily. The other bigger advantage is you can also decenter the rexis on the bag where you want it. I mean, decenter the rexis so that it is centered on the bag in case of subluxated cataracts, and definitely makes life much easier. And then you can go ahead with the regular CTS and CTR as you would require. Again, post RK is just to mention, this is again one of the caveats where you can go wrong. So because the RK cuts can impede the femtosecond laser delivery in those areas, you have to be a little careful and separate the rexis completely, because in those areas you can get a tag. Now this is a 8-cut RK. I think I had a 4-cut RK. Maybe I have not removed it, where I thought it was just 4 cuts, everything else is gone off well, just removed the rexis without really taking adequate care, and there was a small tag in that area which caused a small extension. Fortunately, it didn't extend into the PC, but then that is something which needs to be kept in mind. Is again post ICL. Again, what we have to do is increase the offset and make it a little more posterior offset, as the sometimes the laser focus might actually create an impression on the ICL rather than on the anterior surface of the lens. So minor adjustments might be required. But after that, once the parameters have been adjusted, the focusing has been adjusted, the outcomes are just as good even in post-ICL cases as it is with the regular cases. As you would see, already the rexis has been completed, but the focusing can be a little altered. This is one of the very first cases, but subsequently we have increased the offset and made it a little more posterior, and that also improves the outcomes. This is just a video with an intax. Again, the intact segment, the edge of the intact segment can also affect the focusing of the laser, whereby the rexis can be affected. And again, it needs to be separated nicely before you go ahead with the cataract surgery. The disadvantage, a couple of minutes, I'll just quickly finish the disadvantages, where in small pupil is really the only area where a femtosecond rexis is a slight disadvantage. So one thing is the femtosecond laser delivery itself can induce some amount of meiosis, and nicely dilated pupil at the time of dock on table looks a little smaller. Yes, it does dilate with adrenaline, but one of the reasons is there is an intraoperative meiosis because there's some release of prostaglandins which causes a reduction in the pupillary diameter and some amount of pupillary meiosis after the femtosecond laser delivery. This is very well documented. Factors which increase the meiosis are increased fragmentation time, more energy which is being used, and the lag time of greater than 40 minutes. You would think that suction would actually have an effect on causing some amount of meiosis, but it really doesn't, and there is even the duration of suction doesn't seem to have an effect on the amount of meiosis, doesn't seem to correlate. I'll just go on to the... So some of the ways which you can adjust is either you can manually adjust the size of the rhexis. One of the advantages in the LensX platform is you can just be 0.1 millimeter away from the pupils. But whereas in the Catalyst platform, it allows you only to have a minimum of 0.5. So because it's 0.5, you lose almost a 1 millimeter in terms of diameter. So if you have a 5 mm pupil, you get only a 4 mm rhexis. So what you can do is you can manually slightly adjust the pupillary size to go closer to the border, and also use what we call the pupil maximized function, wherein it tries to maximize and center the rhexis to the available dilatation of the pupil, even if there is a slightly eccentric dilatation in the pupil. So these are a couple of things that you can do. Cases have reported of using iris hooks as well as Malugin rings in the OR, and then going ahead and doing the laser dock. We haven't done it because we don't have it within the same OR, but if in center you have the laser machine and your operating microscope within the same OR, then yes, you could do that as well. Yes, you have to maintain sterility, and that's one of the challenges as you're opening the AC. Also, the low suction pressure in these modern day devices ensures there's no collapse of the anterior chamber. But some things we have to keep in mind is we need to have a uniform refractive index for the laser focusing and laser delivery to happen. So either the chamber should be entirely saline or entirely uniformly filled with viscoelastic. So both these have found to be good. And again, whatever you're filling should be in room temperature, and increase the offsets a little bit so that you don't have any incomplete tags, and use the dimple down technique. This is just one example where they have shown that there is a tag which has formed an incomplete rhexis, possibly because of the non-uniform focusing of the laser. Thank you so much for your kind attention.
Thank you, Dr. Shreyas. Is there any modification you would like to make in your rhexis for a hypermature cataract or a hard cataract? Any changes? You can use the mic here.
So, hard cataract, not as much, madam. I mean, if it is brown or black nuclear cataract also, rhexis maybe we can make it slightly larger, just more for the ease of the surgery. But other than that, not so much for hard cataract. But in Morganian cataracts or in intumescent cataracts, where the chance of some egress of fluid can cause, before the laser delivery is completed, can cause the rhexis to extend. In those areas, trying to reduce the amount of laser delivery time is useful. Yes, there can be small areas where you may have some uncut areas, but you can stain and then just go ahead and remove it, rather than having the risk of extension in those cases. Can hear you, sir. Yes, sir.
Can you please switch on that?
How to center that pupillary capsular axis? Because usually in open we are usually pull the lens and then
in what cases, sir?
In subluxated cataracts.
Particularly.
Sir, if it is so subluxated that it is not even visible within the pupillary axis, then yes, it is difficult. But in the case which was shown, sir, because fortunately the pupillary dilatation was very good. The subluxation was large, but the pupillary dilatation was good. So as long as it's within the pupillary area, you can decenter the rhexis as much as you want. But if the pupil is also small and the subluxation is large, then yes, the Femtosecond is not going to provide an additional advantage unless you go ahead like I showed in those cases where you put in a hook or Malugin ring, enlarge, then go ahead and do the dock. So that is an option. We don't do it because ours is not within the same theater room. We have to shift the patient.
Do you have a tried of a 2 millimeter Axis for the whatever is available, and then because it's always a soft cataracts, so then you extend the Axis manually?
Yeah, that is an option that has been described by some surgeons, because you do it where the the laser rays would fall, and then manually you extend it. That is an option. There, I think one of the advantages of doing a manual surgery rather than a laser surgery is that you can go beneath the iris and hypothetically create that rexis through that region, which is not possible if the pupil is covering that area. But the perfection and the roundness and the lack of runaway of the rexis is ensured by the laser. But like you mentioned, sir, you can always create a smaller rexis within that zone, and then later on, after fixing everything, you can increase the rexis. Thank you for that.
Only quick thing, sir, is that a very small rexis also makes life a little difficult, because you want to stretch it with your capsular hooks and then do the rest of the surgery. So if I am going to end up with something very small, I would rather, as I'm initiating, you put in hooks, initiate the capsular hooks, and then continue the rexis, so that I have sufficiently sized for the subsequent steps of the surgery.
Here, Shreyas, the only thing I would like to differ with you is that I'd rather put a capsular tension ring than a hook, because the hook stretches the margins of the rexis, whereas a tension ring will be at the fornix and it will
You mean
stretch out
capsular
the
hooks, not tension ring? Capsular hooks, you're saying?
No, I will
So
put
CTR.
a capsular tension ring because
Okay.
it stretches the fornix,
Fornix,
and
okay.
not the margin. So that when
Okay.
you tear the rexis, there won't be strain on the
Oh,
margin.
that's a
so
nice
a
idea.
hooks should not be put in a small rexis.